Hello, friends. So, I'll be giving a brief overview on this topic, early appropriate therapy in patients with high risk for fungal infections, with a specific emphasis on amphotericin B. So, this talk, I gave it as part of critical care for a group of African doctors who had come from various countries like Ivory Coast, Nigeria, Ghana, and few other places. So, it was more of an interactive session. So, but I had to give this particular overview. So, So when we talk about, obviously, when we talk about fungal infections, the predominant fungus that we deal with is with Candida. 80% of the time, the fungal infections is due to Candida, and 20% it will be due to the molds. So it can happen, these fungal infections can happen in immunocompetent and in immunosuppressed. And pulmonary aspergillosis is the more commoner one that tends to occur in non-Candida, the 20% of mold infections that happens. Typically, aspergillus is a commoner sort of a fungus that tends to occur. And there are multiple epidemiological studies which have very clearly shown around 70 to 90% would be caused by Candida and aspergillus, and another 10 to 20% by other molds and invasive mycosis. So it is shown that invasive fungal infections kills more than 1.5 million patients annually globally. And this mortality tends to be much higher or increases, especially in hospitalized patients. And they tend to occur in immunosuppressed sort of a patients. And more than 90% of the deaths worldwide has been found to be cryptococcus. This is just a morphological feature how cryptococcus looks, or aspergillus or candida. These are the three commonest fungal infections which attribute to 90% of deaths globally is what has been referenced. And more than 90% of invasive fungal infections tend to happen within the hospital. And mortality in these patients ranges from 60 to 95%, more so in immunosuppressed individuals. So this is the sort of a backdrop of epidemiological burden that we have. And when we say candidemia, it is presence of Candida species in blood. And when there is Candida in blood, there is high mortality. So mortality can vary from 23 to 57% within 48 hours. And some references say up to 34%. And if these patients are untreated, the mortality can go up to 63%. And it tends to account for 5 to 15% of healthcare associated infections. And if you look at all this epidemiological data, so this was a big sort of a global data of prevalence of fungal infections. If you see the 62% of the positive isolates were gram negative, 47 were gram positive, and 19% were fungi. So this is the sort of epidemiological burden. So predominantly globally we deal with gram negative followed by gram positive. The third one would be always fungi. And again, this is epidemiological data that it comes in the fourth commonest sort of a speciation that in the cultures that was obtained in 49 US hospitals. So when you look at the World Health Organization, in 2022, they put out the fungal priority pathogens. They tried to prioritize which are the fungi which needs to be put on high priority. They divided into three elements. So critical priority, high priority, and moderate priority. So critical priority, cryptococcus, because this has been increasingly found, especially in HIV patients and immunosuppressed, which we tend to under-recognize. So because the drug of choice for these would remain amphotericin. So cryptococcus, they put in the critical priority, followed by Candida auris. And Candida auris, we know that azoles, they're resistant. You cannot give azoles in Candida auris. So the drug of choice are echinocandins, or amphotericin B is something that could be considered even in Candida auris. Aspergillus. Aspergillus is put in critical priority, and albicans. So these are the critical sort of a fungi identified by WHO to be put in the critical priority. In the high priority, they put on Candida glabrata. So these are the glabrata looks. Then Candida parapsilosis, Candida tropicalis have been put in high priority. Histoplasma is put in high priority. Fusarium is put in high priority, and mucorales, which are mucormycosis, has been put in high priority. And mycetoma. So these are the high priority ones WHO has classified. The medium or the moderate priority group, they put pneumocystis in moderate priority, Candida krusei, coccidioides, and Lomentospora prolificans. So these they put in the medium. So this is the WHO sort of a stratification of the fungi which needs to be put on priority. And when you look at the risk factors for Candida, I think the best reference we have was from this study where there are 11 risk factors. And as you see, the highest odds of anyone having Candida is the presence of CVC catheter. The second highest is the use of stress ulcer prophylaxis, or someone who is in ICU itself is a risk factor for Candida. And someone having Ryle's tube itself, the odds of them having Candida is 3.7, and antibiotic usage 1.5, TPN Apache. So I've just put in a pictorial format to you recall as to what are all the risk factors. And these are all these risk factors you would typically see in an ICU patient. Someone on a RT, someone with a CVC, someone with a PPI, someone receiving antibiotics and sepsis, renal failure, and having undergone some surgical procedure and TPN. So this is the typical profiling of patients we tend to see in ICU, which all constitute as a risk factors for Candida. And any immunosuppressed patients is a major risk factor for invasive fungal infection. If you see, just look at the box in the red, where any patients who is immunosuppressed, like neutropenia, solid organ transplant, hematopoietic stem cell, or HIV, if you look at the type of fungus, it's not only Candida. You will see a lot of molds, because if you see solid organ, you'll see Cryptococcus, you can see Aspergillus, and prolonged neutropenia, they are at a risk mainly for Aspergillus. And if you have hematopoietic stem cell, you will see pneumocystis or mucoroids. So what I'm trying to say is, in ICU patients, especially when you're dealing with immunosuppressed, you need to have a high index of suspicion, not only for candidemia, but for mold infections, which may be more prevalent, like Aspergillus, like pneumocystis, like mucorales, so on and so forth, and Cryptococcus. So what are the risk factors for mold infections? So anyone who has neutropenia less than 500 for more than 10 days, who are undergoing some sort of a chemotherapy, acute myeloid leukemia remission, or any leukemia remission induction, or who have undergone allogenic, they are all at a risk for mold infection. And you should not think only about Candida. They are at a risk for mold infection. HIV patients, someone with a end stage disease, which we commonly see in ICU, like liver disease, or someone with DKA, someone with end stage COPD. Because why COPD? Because these patients are on long-term steroids. Someone who is recovering from ARDS, autopsy has shown they are having a high risk of having Aspergillus. And someone with a pulmonary fibrosis, or you have a cystic fibrosis, or someone with a granulomatous disease, tuberculosis. All these are at risk for having mold infections. And someone who is undergoing solid, because these are the days where most of our tertiary care ICUs, we deal with renal transplant, liver transplant, lung transplant, so on, and they're all at a risk for mold infections and graft versus host disease, or someone who's on a steroids. So this is very important for intensivists. If someone is on steroids for more than 3 weeks at 0.3 mg, 0.3 mg per kg for 60 kgs, amounts to 18 to 20 mg per day for more than 3 weeks, they're at a risk for developing mold infection. And someone who is on immunosuppressants for 3 months, or immunosuppressants against T helper cells or anti-TNF, all these are at a risk for developing. So these are the risk profiling for mold. So you saw the risk profiling for Candida. Candida is any typical ICU patient, but for mold infections, these are the typical sort of a triggers or the context for them having mold infection. So now the question is, why diagnosing invasive fungal infection is difficult? Why is it that it is difficult? Because most of the patients we deal with are immunosuppressed, and doing invasive procedures for them to get the tissue is risky, and they don't mount the inflammatory response. They have a suboptimal inflammatory response, and that becomes difficult. And there are no distinctive signs and symptoms of fungal, because in ICU they can just have a smoldering fever, or they can have a sort of a baseline sort of a temperature that doesn't settle down. So they may not have any distinctive features to suggest that there can be fungal infection. So there are no definitive signs to indicate, okay, this patient may have fungal infection. And I said antibody response. If you do serology tests also, antibody response are suboptimal. And histologically, identifying these different funguses needs a lot of expertise, and many of them look similar. And I showed you all candidas, there may be very subtle difference. And identifying in histopathological specimen also can be challenging. And the conventional cultures that you use, they do not show a sort of they do not give immediate answer, because the growth of this is very slow and they have low sensitivity. So these are some of the reasons why diagnosing invasive fungal is difficult. And what are the challenges of diagnosing for fungal infection? Because turnaround time for conventional tests like serology or more so cultures, turnaround time is very slow. It is laborious, and they've shown that blood culture yielding yeast occurs in only 50% of the time, 50 to 95, mold only 1 to 5. It is very hard to speciate or to grow molds in the culture. So that's why it becomes, that's why you may have to depend on biomarkers like galactomannan, so on and so forth. So, and turnaround time for the cultures for yeast is 5 days. For molds, it's 4 weeks to grow this mold. That's why we may have to rely on beta D glucan, we may have to rely on galactomannan, so or we have to rely on PCR because using conventional cultures will take much longer time and they do not grow. So these are some of the challenges. And because of these challenges, if you delay the treatment, studies have very clearly shown with every day's delay, there is sequential increase in mortality, and which we have seen in any infections. So every hour delay increases the odds of their mortality. This was one study from Japan where they showed if you delay, the mortality also sequentially increases. Like early, they had mortality of 30%. This is in invasive pulmonary aspergillosis. So late initiation of therapy, mortality was 42%. And empiric antifungal therapy within 24 hours is usually started only in 30% of the cases. More than 12 hours delay in initiating antifungals has shown to increase mortality by odds of 2.09 fold increase in mortality with delay. Like in any other gram-negative infections, delay in antibiotics increases the odds of mortality. Same applies to even fungal infections. And now about starting, when do we suspect that someone may have this fungal and would want to start early antifungal treatment? Someone who is in hospital for 7 days. So look at this. This is like we have fungal score. It's very similar. Someone who is hospitalized for 7 days and who has received already antibiotics for bacterial infection for 7 days, or someone is having an indwelling CVC catheter for 7 days. They are at a risk of developing fungal infection, or you should have a high index of suspicion initiating antifungal therapy. Plus, any two of these, someone receiving TPN, someone having undergone surgery, someone who is having pancreatitis or undergoing dialysis or who are on steroids. So, any two of these, along with CBC or bacteria, who has remained in ICU for 7 days, they are at a risk of developing fungal infection. Plus, colonization of candida in one of the places, you are justified, or one could justify based on the clinical situation. If there is an index of suspicion of fungal, antifungal therapy could be initiated in this sort of a situation. And if you look at the spectrum of activity for systemic antifungal agents, just look at the column marked in the red box, that all the fungi that we tend to see, the critical fungi are Candida albicans, Aspergillus, Cryptococcus. There is one drug which is effective against all these three, is Amphotericin B. And even for all the high sort of a priority fungi also, Amphotericin B seems to be effective because there is variable effectiveness with regards to other antifungal agents like flucytosine and itraconazole, voriconazole, posaconazole, so on and so forth. So, which means Amphotericin B has a uniform effectivity against Candida and against the mold infections, mucorales, fusarium, so on and so forth. So now we need to understand what are the key characteristics of the available antifungal agents for treating invasive. What is the key characteristics? When you look at spectrum of activity, fluconazole is limited because fluconazole is not effective against Candida glabrata. It's not effective against Candida auris. And in India, we tend to see more of Candida auris. Echinocandins has a good wide activity. Amphotericin B also has a good activity. Antifungal activity, fluconazole is fungistatic and echinocandins is fungicidal, amphotericin B is fungicidal. But the third row I want you to focus on, anti-biofilm, which we tend to see in ICU. With the indwelling catheters, fluconazole has very low biofilm. Echinocandins has variable, but amphotericin B is the drug of choice if you are dealing with biofilms. If you have a fungus with an indwelling catheter and you are not able to remove the catheter, especially when they have a low platelet count or where access is difficult, which typically tends to happen in our ICU transplant situations, biofilm penetration is very good with amphotericin B. Safety is good in fluconazole, very good in echinocandin. And amphotericin B, of course, we have nephrotoxicity, but we tend to use more of liposomal amphotericin B. Evidence based on randomized controlled trial, fluconazole is shown to be inferior to echinocandins. Echinocandins is good, amphotericin B is adequate. If you look at guidelines by European Society of Clinical Microbiology and Infectious Disease, For fluconazole, it is a low recommendation, C1, A1 recommendation for ECNO, which is strong recommendation, and B1 recommendation for amphotericin B liposomal. And cost is low, fluconazole cost is low, echinocandins is medium. Liposomal and echinocandins now in India are pretty similar, although I mentioned it as high here. So now, so this is the available agents and these are the characterization. So what is the mechanism of action of antifungal agents? So mainly most antifungal agents act on preventing the cell wall synthesis or lysing or creating disruption of the cell wall. So ergosterol, which all the fluconozoles, azoles, they inhibit cytokine P1440 responsible for synthesis of ergosterols, which are the building blocks for the fungal cell wall. And polyenes, which is amphotericin B, they bind to sterols and cause cell lysis. And the echinocandins, basically they bind to this beta-1,3 glucan synthase. As you see, as the name suggests, the glucan synthase is responsible for synthesis or for for creating the cell wall. So echinocandins inhibit this enzyme which is needed for the creation of the cell wall of the membrane. So these are the typical mechanism of action of the available antifungal agents. So what are the available antifungal? Azoles, we have fluconazole, that's the dose 800 mg or 12 mg per kg we give, followed by 400 mg per day. And voriconazole is superior to fluconazole. It has a lower MIC and it has increased effectiveness against Candida krusei. Posaconazole is available as oral, used as a prophylaxis for graft versus host disease and stem cell transplant and hematological malignancy. Polyenes, amphotericin B, dosage is 0.5 to 1 milligram per kg per day, but it has no effect on Candida lusitania. Liposomal amphotericin B, which we tend to use more often now, the dosage is 3 to 5 mg per kg. And there are other amphotericin like amphotericin B lipid complex or amphotericin B colloid dispersion that are available as well. Echinocandins, caspofungin dose is 50 mg OD, anidulafungin is 100 mg OD, micafungin is 100. So these are the armamentarium of antifungal agents which are available. And the common ones we tend to use is voriconazole for aspergillus, and we use amphotericin B for covering molds, especially in COVID. We saw mucormycosis, this was the drug of choice. Echinocandins, we use any of these. So now we'll talk about what is the positioning of liposomal amphotericin B in patients with hematological malignancy. For invasive aspergillosis, all the guidelines, IDSA, European Society of Clinical Microbiology and Infectious, ESCMED, and European Conference in Leukemia, EKIL, all these recommend either voriconazole or isavuconazole, but voriconazole has a higher recommendation from IDSA. But there can be azole resistance also. So if you have aspergillus with azole resistance, liposomal amphotericin B is the second best alternative if there is some sort of an azole resistance that is prevailing in aspergillus. And this was the study that came from the Netherlands. In 45 patients, they used combination, various combinations, caspofungin plus voriconazole in 42%, caspofungin with liposomal amphotericin B in 24%, and liposomal amphotericin B with voriconazole. Clinically, there was no difference in outcome between any of these combinations. So whether you can use combination, I think that it can be determined by you, but there was no clinical outcome difference, and response rate was 73%, and mortality in these patients was 17%. So this was a landmark study, CFM study mycosis in aspergillosis that came from Italy. So what about empirical and preemptive? What do we understand by empirical therapy in neutropenia, in febrile neutropenia? Empiric is in febrile neutropenia, when they have persistent or recurrent fever, starting antifungal therapy is called empirical. Preemptive is where there are clinical signs, radiological findings, or galactomannan positive, which are suggestive that patient may possibly have fungal infection. So you would either start treatment empiric based on your, as the name sounds, or you have certain signs and signals suggesting that patient may have fungal is called preemptive therapy. So there are studies to see whether there is any difference in starting antifungal therapy between empirical or preemptive. And they found liposomal amphotericin B, either empirical or preemptive, survival at the end of 14 days, there was no difference. Either you start empirical or preemptive, it was non-inferior. But what they found is when they started empiric, only out of 78 patients, only 3 had a confirmed infection. In preemptive, where they relied on certain signals or cues, clinical cues, radiological cues, 12 patients out of 73 had a proven infection. And in allogenic hematopoietic stem cell transplant, survival at 100 days with empirical was 37, with preemptive it was 57%. So preemptive was much better because your ability to have a precision with regards to targeting the fungus was better, so survival was better, and that was statistically significant. So whether there are any studies comparing which fungal agent is superior, so there are certain studies to see whether amphotericin B is better, caspo is better, or oriconazole. So this was one study which compared between liposomal amphotericin B, caspofungin, and oriconazole. There was no difference in the outcome between caspofungin and liposomal amphotericin. But with regards to oriconazole, it did not meet protocol-defined criteria. And for febrile neutropenia, there is no regulatory approval for empirical therapy for oriconazole at this point of time. But liposomal amphotericin and caspo is something that one could think of. So this was one study that came in NEJM, which compared oriconazole compared with liposomal amphotericin B for empirical antifungal therapy in patients with neutropenia. So they had 836 patients, 415 in the oriconazole group, 422 in the liposomal amphotericin group. As you see, the success rate, there was no statistically significant difference between oriconazole and liposomal amphotericin B. This is in febrile. Although in febrile neutropenia, there is no regulatory recommendations for use of oriconazole as empirical or preemptive. This particular study showed there was no difference. Either you use liposomal, but if you see, there is trend towards favoring liposomal amphotericin B in this particular study. And what about role of liposomal amphotericin B in the ICU? So diagnosis and treatment of invasive fungal infection in ICU typically we see in hematological patients, solid organ tumor, or in transplant patients or immunosuppression. In immunocompetent patients also, these studies have shown there is increase in the risk of invasive fungal infection, especially in diabetic patients. 23 to 36% of the diabetics were at a risk for invasive fungal. Someone with foot ulcers. So these are the patients who are at a risk for developing the mold infections, especially with mucorales or rhinoorbital mucormycosis. And we saw this in COVID, where they were treated with steroids. They were all at a higher risk of them developing mold infections. So diabetics, one should have that index of suspicion that they are at a risk of developing not candida, but they are at a risk of developing mucorales or mold infections is what these studies have shown. And when you are dealing with aspergillus, the treatment is surgical debridement, and the only antifungal therapy of choice is liposomal amphotericin B, 5 to 10 milligram per kg. And of course, you have to treat underlying DKA. In candidemia, is there a role for amphotericin? There are three specific areas in candidemia where amphotericin could be thought of is intra-abdominal candidiasis or complicated pancreatitis. Empiric therapy, who have had previous exposure to azoles, echinocandins is the first choice, and liposomal amphotericin B remains the equally good choice in this complicated intra-abdominal fungal infection, complicated pancreatitis in who have been on a previous azoles. So one could think of echinocandins or amphotericin B, or this is a typical situation where amphotericin B could be thought of as a priority even before the echinocandins, where you are unable to remove the line and you want to penetrate the biofilm. Liposomal amphotericin B becomes the first choice. And if it is echinocandins, anidula fungin has shown to have a better biofilm penetration. In septic shock, if they have candidemia or fungal invasives, source control have to be achieved. Treatment has to be started within 24 hours. Even then, case fatality rate can be more than 50%. And if untreated, it can go up to 97%. So which means fungus in blood, you have to start ASAP and attain good source control, because otherwise mortality rates are very, very high in blood invasive fungal infections with a candidemia or molds in the blood. So what about treatment of Candida auris? Candida auris, none of the azoles work on auris. Fluconazole is fully resistant. 100% azoles are resistant. Amphotericin B, 25% of amphotericin can be resistant to amphotericin B also. And 5% of Candida auris can be resistant to echinocandins also. And Candida auris shows resistance to either of these three 70% show resistance to at least one, 25% show resistance to two, and 1% shows resistance to all three. So which means Candida auris is a wretched bug. So we need to be very cautious, and the drug of choice is only echinocandins and to some extent amphotericin B. So as per Gillis, it is shown even in immunocompetent individuals, 2% of them can have aspergillus, and autopsy has shown 1% of ICU patients can have uh, aspergillus. And ARDS patient, this was the reference study from France, where they did autopsy in ARDS. Clinically, 8.3% had, in autopsy, 15% of the ARDS patients showed aspergillus. And VAP patients, 12.4% had aspergillus. So this was a retrospective study again from a Dutch and Belgian mycosis study group. Influenza pneumonia patients, 19% of them have had aspergillus. 5% of CAP patients have had aspergillus. COVID-19, 3 to 30% of the patients have had aspergillus, which means to say aspergillus is very much prevailing in ICU. And once anyone who is recovering from pneumonia not getting better, anyone from ARDS not getting better, one should at least evaluate, do galactomannan and try to pick up if there is underlying aspergillus that may be present, because if you do not treat, these patients are going to die. And guidelines is for aspergillus, voriconazole is the first choice, and liposomal amphotericin B is the second choice, and especially if MICs are more than or equal to 2 milligram per liter. And mucormycosis we already saw, and there was this study from France, 40 patients with mucormycosis, where they used high dose amphotericin. So I said 3 to 5 milligram per kg is the liposomal. In this particular study from France, they used 10 milligram per kg in 40 patients. We know mucormycosis we saw in COVID have very high mortality. Then they used 10 mg per kg of liposomal. Response was 45%. Survival at 12 weeks was 62%. 40% of them have had AKI. So mucormycosis, the first drug of choice is always amphotericin, and please consider high dose amphotericin because response rate was found to be better from this particular study. What about combination antifungal therapy for rhizopus or mold infections? So these are multiple studies where they showed combination. They used amphotericin B with echinocandins. 31% of them have had amphotericin B with echinocandins. They did not find difference between combination therapies. And this was another study done in 106 patients comparing amphotericin B monotherapy versus amphotericin B with echinocandins. They looked at 6-week mortality. There was no difference. But then there was one study which came in a small group, 21 patients, where amphotericin B monotherapy had less response compared to amphotericin B with echinocandins, where all of them responded. So combination therapy, the verdict is not out whether combination is better or monotherapy is better with amphotericin B, because 2 studies showed no difference with combination. 1 study showed better response with combination. So this was the publication we made, invasive mucormycosis following COVID pneumonia in 2020. In the thick of COVID, we presented the case series. So summing up, in patients with abdominal fungal infections or abdominal candidiasis, where they have a complex anastomotic leak or who have had abdominal surgery, viscous perforation, empiric therapy, echinocandins is the first choice, especially if they've had a previous azole therapy. Liposomal amphotericin B could be also considered. And especially in ICU, if someone is having an indwelling catheter, you're not able to remove the indwelling catheter, liposomal amphotericin B is the first drug of choice because it has good biofilm penetration. And this is a recommendation by European Society of Clinical Microbiology, and Anidula fungin is the drug of choice because that has a better biofilm. In febrile neutropenia, voriconazole is not come as a recommendation by any societies. IDSS suggests in febrile neutropenia, liposomal amphotericin B is a good alternative if you are meant to cover the molds, because we saw in febrile neutropenia, the major risk for mold infections is febrile neutropenia. So liposomal amphotericin is a good choice. Although many hematologists tend to use voriconazole, it does not come as a recommendation because voriconazole does not have a wide coverage for all the mold infections as well. And if you are aspergillus, guidelines suggest voriconazole is the first choice, but liposomal amphotericin B can be a second line if MICs are more than or equal to 2 milligram. With regards to mucormycosis, we are very clear So this is mucormycosis study group, and this is also European Consortium of Mucor Studies. Guidelines suggest high dose liposomal amphotericin B is the first choice, and isavuconazole and posaconazole can be used as a weaning drug. So when you are dealing with invasive molds like mucorales or emerging new fungi, emergomycosis, histoplasma, fusarium, 20% azoles are ineffective. So you may have to consider amphotericin B as a drug of choice for all these emerging new mold infections. So that's about it, folks. So thank you one and all. So I invite you to submit your valuable work to Journal of Acute Care. So you can visit my website to rehear to this lecture. So thank you one and all.